Don't forget to screen share to the computer. Hello, everybody. Welcome to Fertility Fact or Fiction. And I am your host, Dr. Rahi Victory. We have an exciting show for you tonight with a very, very important topic, which is why do euploid, meaning genetically normal embryos, miscarry or fail to implant? So this is a super interesting topic and something that is critical because a lot of people think that if they just get that genetically normal embryo, they are going to be successful, but the reality is it doesn't always work. They don't always implant, and sometimes when they do implant, they miscarry. And so the question is, what risk factors do you potentially have that can contribute to a failure to implant or a loss of the pregnancy? And so this is a very large kind of meta-analysis systematic review. And we can't go through every single topic, but I will share the paper with you. And that way you'll know about all of the information that was in this, because I think it is a really important paper and topic to go through. We are going to need to screen share. So let me know when you are ready to screen share. Laptop, there we go. So I have Tarek from Ibrahim Strategies Group, my trusty friend here. The two of us should likely be comatose because we had an extraordinarily unhealthy meal right before this show. And hopefully my wife is not watching because she'll probably kill us both. Okay, are we up and showing? Screen sharing? So we need to have screen share. Can you see my article? Okay, whoops. So this is a really interesting little image. Hopefully you guys can see that clearly there. So basically they looked at opening what they call the black box of implantation, what factors kind of contribute to it. And so the traditional things are things like blastocyst quality, maternal age, obesity, and then, a history of repeated implantation failures. So when they broke it down, they looked at it in terms of there's a 45 to 65% live birth rate per euploid blastocyst transfer. This is a number I frequently quote people for North American and European statistics. I will happily tell you that our rates are much, much higher than this. But this is the standard of what's available out there. If you get one genetically normal embryo, generally speaking, you're going to get about a 50% chance that that embryo is going to implant and turn into a live birth. So they looked at all of the different things that could be contributing: embryonic factors, maternal factors, paternal factors, clinical factors, lab, and then they looked at all the different features of this. And so when they spat all that into the grinder of information, they found that if your inner cell mass was grade C or lower, so that's the actual part that's becoming the baby, was graded a C grade, there was a 63% decrease in success. If your trophectoderm, which is the portion that's becoming the placenta, was grade C, that was a 47% decrease. If the embryo itself had a lower grade than BB, 60% decrease, and so on. So I'm going to go through some of that information with you tonight so I can show you all of this. But this was kind of their graphical presentation, and probably something I'm going to include on our website. And people can look at it, because this kind of goes along with our embryo math idea. Now, not all of the studies were necessarily perfect here, but it's definitely an important thing to look at. Okay, so we are going to go into the body of this. So here's basically how they did it. They found a huge number of articles, 1,608. No additional resources from scanning through those ones. After they removed duplicates, they were down to 1,554. They screened them. They had to exclude 818 for various reasons. That's a lot of exclusion, so you always have to worry about bias. I had a friendly discussion recently with someone that has started this phenomenal program where they have a group of physicians reviewing information for patients to access online. And she said, all of their reviews were unbiased. And I said, there's no such thing as an unbiased review. The physician will go into a data selection process with something in mind. And if they feel that that study doesn't quite fit the picture of what they think is right, they may exclude it on valid or maybe not entirely valid grounds. And that can skew where the data takes you with all of this. So they had 736 articles left. They removed another 323. But at the end of it all, they had 413 that went into the qualitative synthesis, which is descriptive study, and 74 that were included in the quantitative synthesis, which is actually using those studies for the mathematical analysis. That's still a lot of studies. It's a huge body of literature. It's a huge number of studies. And so they got reasonable numbers, although you'll see as we go through this, not every single category they looked at had a huge number of patients, and that can be concerning for some of their conclusions. Okay, we're going to skip a whole bunch of unnecessary slides here, and I'm going to take you to where the important stuff is. We are almost there. Okay, that's the first one there. So I'll expand this so you guys can see it. Hopefully that's kind of full screen. You can see that well. Perfect. Okay, so in the first category, it was grade C inner cell mass. So remember, when you have an embryo that's graded, the embryo gets a number in most grading systems. That's the degree of expansion of the embryo. The system we use goes from 1 to 6. And then the first letter grade describes the inner cell mass, which is the portion of the embryo that's going to become the baby. And the second letter is the grade given to the trophectoderm, which is the portion of the embryo that will shortly become the placenta. So we've presented on this show before that if you have a lower grade embryo, your chances of implantation are lower. Sure enough, they included about 7 studies here. Total number of patients was substantial, 6,403 in the AB category of embryos versus 470 in the C category of embryos. So they compared the live birth outcomes for embryos graded AB for the inner cell mass, so that's the part that's becoming the baby, to the ones that had a C grade inner cell mass. So when you come in and they tell you your embryo is a 4CB, that means the inner cell mass portion has a C grade. And as you can see, because the triangle, the diamond on there is on the, let's see if I can draw it for you. As you can see right here, because that diamond is on the left side of that bar, it shows a reduction in success. And you see that right here, there is a 63% reduction in live birth if you have a C grade embryo. So and these are genetically normal embryos, so don't forget that. All of these were genetically normal embryos. So if you get a genetically normal embryo, but it's a C grade, that embryo will not do as well as one that is a BB or an A graded embryo. So very, very important to remember all of that stuff. When you look at the next topic, sorry about that, guys. When you look at the next one going down, it was the trophectoderm. So what if the trophectoderm is C grade? And you very similarly have a significant reduction of 47% in the success rate when you're dealing with a C graded trophectoderm. So again, you get a 3AC embryo, you're still going to see almost a halving of the chance of a live birth, even with a genetically normal embryo, because the trophectoderm portion of the embryo is just simply not as strong as the rest of it. So huge, huge importance for patients who think that their amazing quality embryo, because it's euploid, is going to solve all of their problems. And there is a lot of data tonight, so I'm going to try and get through it as quickly as possible for you, because I want you guys to be aware of all of the factors that can contribute to this. What if the whole blastocyst was considered less than BB? So they looked at it as a whole, poor quality. What if it was graded as a poor quality embryo? CB or CC or whatever the grade was. So again, you've got this very significant 60% reduction in success when the blastocyst grading is less than a BB grade, which they showed independently when they looked at the trophectoderm and the inner cell mass, but now they're showing that en masse, when you look at the whole embryo, obviously it's equally significant, if not more so. Okay, so then they went on and they looked at some other factors. So here's another one where they looked at day 6 and day 7 embryos. So people ask on the show, they were asking last week, what if I have a day 7 embryo? What are my chances? Are day 5s as good as day 6? So in this study, they compared day 6 and day 7, which they lumped together. And I think that that's inappropriate because a day 6 and a day 7 are hugely different, right? Day 7s don't do nearly as well. But they lumped them together in this study with a very high number of embryos, so 4,627 versus 6,716 in the day 5 group. And they did show, again, about a 50% reduction, 44% reduction in the chances of a live birth with a genetically normal embryo that is day 6 or 7 compared to day 5. Now, they unfortunately did not segregate this into day 6 and then separately day 7, which definitely would have changed the numbers because there are many studies that show that there is not a difference between day 6 and day 5, but there is a difference, which I've talked to people about on the show, between day 7 and a day 5 or even a day 6. So I wish that this had been pulled apart into day 6 and separately day 7 and then comparing those to day 5. We don't have that data from this study, but they're saying that if you're day 6 or day 7 lumped in together compared to a day 5, you're not going to do as well, and that's quite significant. So for those of you that have day 6s, please don't panic. Your chances appear to be equivalent with a good day 6 compared to a good day 5. But for those of you with day 7 embryos, this again suggests that there is a compromise in the outcome, even when the embryo is genetically normal. So I've heard people say, I was told that my day 7 embryo will have the same chances because it's genetically normal. That's just not the case. That's not true. Okay, moving on. I think this one was simple. There we go. There's another one. Okay, so now we got into some things that they looked at that probably aren't all that relevant. So they did one examination where they looked at embryos that had had double PGT analysis, one from the trophectoderm and one from the culture media, and they looked to see if you had live birth rates that were the same as those that had a difference with the embryos being biopsied from the trophectoderm and having one response for being normal or abnormal versus what they got from the spent culture media. There was no difference. There is, however, a borderline difference in women that are older than age 38. So it was right on the cusp of significance. So you can see right here, if the woman was older than age 38, it appeared that there was a 13% decrease in success. Now, if you see right there, it says 1, and that number 1 is really important because that means that it was right on the border of significance. We need a few more numbers in order to determine if this is significant or not, but certainly the trend is headed in that direction, and that's an important thing for us to all be aware of. So if you are older and you're producing genetically normal embryos, and we've shown this on the show before as well, it does appear that women that are older, even when their embryos are genetically normal, they do not have the same chance of success as someone that is younger. So that is, again, an important factor to consider. Women with a diagnosis of infertility showed similar live birth rates with euploid embryo transfers to those with unexplained infertility. So if you had unexplained versus any other diagnosis of infertility, your outcomes were the same. So for those of you that have unexplained infertility and are wondering if your euploid embryo will give you the same chance of success as someone that has male factor or tubal factor or endo or any of those, it appears to give you the same chances of success. What about women with PCOS? Again, no difference. The confidence interval crosses 1. You can see here that our little diamond is crossing over that line. And so women with PCOS actually have the same chance of success as women who do not have PCOS. They did the same thing for diminished ovarian reserve. So this one was very, very impressive for me and very, very important because women that have diminished ovarian reserve there are many studies out there that demonstrate that they are at a higher risk of having genetic abnormalities and likely lower chances of success. But the question is, if you get a euploid genetically normal embryo from a woman that has diminished ovarian reserve, does that embryo give you the same chance compared to someone that doesn't have diminished ovarian reserve? And in this study, it actually shows that it does give you the same chance. So as long as you get that genetically normal embryo, if you're a 34, 35-year-old, but your ovaries have become weak, you're still going to have the same chances as someone that's your age that does not have a weaker ovary that you may be experiencing. Again, this is hugely important. We don't have a lot of data on this, so I think it's really critical. I think we still need to share TikTok to the thing. I don't know if you've done that yet or not. So what about women with endo? Huge question. You got to swipe down. Yep. So women with endo also interestingly showed similar live birth rates. So I think that is tremendously, tremendously important, because certainly we know clinically that women that have endo have a much harder time. But in this study, they're saying if you get a euploid embryo, that your success rate is going to be the same regardless of whether or not you have endo or not. And I think that's important. Having said that, I'm not quite sure I believe it. And keep in mind that the numbers here were very, very small. There's only 350 patients with endo compared to 3,607 that did not have endo. And this one is complicated because not everybody had surgery. So we don't know if they were classified based on surgical findings or opinion or pain scores or whatever the issue was. So I'm not sure I bite into this one quite as much. It appears to be interesting, but it certainly doesn't seem clinically what we end up seeing typically in our own practice. What about tubal factor? Again, tubal factor showed no significant difference. They had the same outcome as everybody else. A couple more. If you had previous recurrent implantation failure, you can see that in figure 13 here. Unfortunately, there is a 28% decrease in your chances of success. So if you have recurrent implantation failure, merely getting a genetically normal embryo does not necessarily make you the same as everybody else. There can be factors leading to your recurrent implantation failure, which are also going to make it much more difficult for you to get pregnant and stay pregnant with even a genetically normal embryo. And again, this is important because there are studies out there that suggest that if you do absolutely nothing and you just keep putting genetically normal embryos in, you will eventually get pregnant. Yeah, it's probably true, but what if we can tweak for those things, adjust for those things? Can we then improve the success rates even higher? And that's what we do here, and certainly we are seeing much higher success rates than just 50% implantation that this study shows at the very beginning, 45 to 65. We are getting way, way higher than that, almost double their starting point. So we're definitely seeing robust numbers, and I think a big part of that is the fact that we pay attention to details, we review every single element, and we go over all of the potential factors that can contribute and adjust for them before we try and get you pregnant, so that we don't have a situation where you have a recurrent implantation failure. So I think that's really valuable data there. It's critical. Again, the numbers are small, but it's important. And then they looked at recurrent pregnancy loss. Recurrent pregnancy loss was not impacted. And again, this is important because one of the few areas where PGT has been shown to reduce the chances of failure is in women that have had recurrent pregnancy loss. Because if you know that the embryo is genetically normal, you're obviously going to reduce their chances of miscarriage. And that's what this study is supporting. Again, I'll highlight it for you here. And you can see that they had 436 women with it and 2457 without. And there's a 25% reduction in the risk of having a failure if, there's a non-significant 25% reduction, which means there's no difference. They actually all had the same outcome. And you can see that because the diamond crosses the one line, meaning that if you had recurrent pregnancy loss, you still were going to end up with a robust outcome, and you could very potentially get pregnant, stay pregnant, like anybody who did not have recurrent pregnancy loss. So again, very, very valuable information for us. And then one of the last ones, which is a touchy subject, and I apologize, but I think it's important for everyone to see. Obese women, and in this study they used the definition of a BMI over 30, showed a much lower live birth rate even when the embryo is genetically normal. So that is a 34%, a 1/3 reduction in your chances of achieving a live birth if your body mass index is high. And that's comparing a genetically normal embryo to somebody who's not struggling with their weight and also has a genetically normal embryo, matching for all of the different factors, including age and everything else. So this is, again, hugely important because we spend a lot of time trying to optimize the health of our patients before we put them through IVF so that they do succeed. Unfortunately, whether we like it or not, weight is a huge part of that. It's a critical part of that. So all of these things are important. Now, these guys also looked at a million other things: estrogen levels, vitamin D levels, your thyroid hormone, selective serotonin reuptake inhibitors, which are antidepressants. They even looked at endometrial compaction. So I think Tarek and I will work on a big video for this where we can come up with each little topic, and then we'll have to do the YouTube thing where people can go directly to each one. But there are too many things to review here, or we will never get to questions. But they did review a bunch of other things here. The endometrial receptivity array, I can't resist this one because Tarek knows I love this. No difference in success. So if you have genetically normal embryos, the ERA test is useless. There is a new meta-analysis coming out, again, showing that it's useless. So please, for the love of God, stop doing the endometrial receptivity array. It is now completely dead. If the dad is older, it does not show a difference, which again was interesting. I thought that it would. There are studies that support the idea that when paternal age is higher, it's a problem. Sadly, here it's not showing that. So tonight the guys are blameless, but only tonight. And I'm sure I'll get blamed for something when I get home, as will Tarek. Together, the two of us. Yeah, I'm always to blame too, man. And then the severe male factor infertility, again, not a factor in this study. So I could go on and on. I don't want to go for too long. The dose of gonadotropins didn't seem to make a difference. Again, there are some studies which have shown that the egg quality can be diminished. But again, you got to be careful when you look at this, because look at the number of patients that they had. There are only 311 patients with high dose gonadotropin exposure. Is that enough to make a firm conclusion on? Not in my opinion, not for something that important, when there are other studies they have not included here. But I think that this study is very much a game changer in terms of some of the data that is presented, and gives us a lot of information. And they looked at everything: embryo culture media, whether it was continuous or sequential media. These are lab things some of you may not even be interested in. Whether there was trophectoderm biopsy and which protocol was used, that actually did make a difference. If your embryo was biopsied on day 3, not biopsied, laser hatched on day 3, you had a lower chance of success than if you had your embryo biopsied later. And we've got a whole bunch of questions coming up, so I'm going to save this for later. But guys, you have to check out this article. It is in Human Reproduction Update. It is very much a game changer. There are some important things here which are important. Here's another one very quickly I'll show you before we go, right here. So for people that want to know about whether or not you can freeze thaw and then refreeze and rethaw, there was a almost 60% reduction in live birth when they did that. Very small number of patients involved, but a huge difference. And finally, very, very important right here, frozen embryo transfer had a 56% increase in success compared to fresh. Yes, I feel validated. I'm very happy about that. So check out this article if you can. If you cannot, let us know. But this is huge, huge, very important information that everybody should be aware of. We will put a video up on YouTube, hopefully this weekend sometime. I'll go through each and every one of these and explain it for you all. So fact or fiction, do euploid embryos all behave the same? The answer is no, they don't all behave the same. Some euploid embryos will have a lower chance of implanting for a variety of different reasons related to the embryo, the lab, and the patient. And I think that that is absolutely critical for people to understand. Getting a euploid embryo does not guarantee you success. And there are programs out there that just tell people, just keep doing IVF, make more embryos, you'll get there. It's not a guarantee you're going to be successful. So keep that in mind when you're deciding what to do, how many times to do it. That is very, very important for you.
Ready?
Yeah. I can't go back on
I'll
TikTok.
Go back
You'll go back? Okay. Carly was asking. I think they're having a battle.
I think there's asking questions.
No, Carly's having a little spat with someone on there. Anyways, hi, Car.
Melatonin before and after transfer is something you recommend for your patients?
It is. We've got a good video on our YouTube channel on melatonin showing how much it actually improves the outcome. So definitely check that out. And it's about a 30% increase in success. So it's good for egg quality when you're going into your IVF. It's probably even better for your embryo transfer. Whether it's a direct effect of the melatonin or the fact that you're sleeping better, and we know sleep has a huge impact on success, no one knows, but it is important for sure.
If you do lab surgery for your patients and you don't see anything, you still put them on Orilissa if their Receptiva test came back positive.
If I what? Say that again?
If you do a lap surgery.
Oh, would I put them on? No, Receptiva is nonsense and it doesn't work, so don't count on that at all.
Do you see more success with Lupron Depot or Orilissa for endo-adeno suppression?
So I haven't seen any studies looking at Orilissa for endo-adeno suppression prior to frozen embryo transfer protocols that went head-to-head against Lupron, so I'm not aware of it. Yeah, I think that we're using Lupron. I'm not ready yet to go to Orilissa. I don't know that you need to go that far back, dude. That's like way back.
I just want to hear the comment that Tarek didn't pick me.
No, I know we will get a little bit of that. So yeah,
That's
that's an inevitability, buddy.
Inevitability.
Yeah, it
At
is
least
an
it was intentional,
inevitability.
they can tell. Okay, we have our first appointment with you in 2 days. We are nervous but excited.
Yep. Yeah. Do I think you should do Lupron and letrozole protocol again before next transfer, Car? No, just the letrozole protocol. You don't need to do, well, you'll do 1 month of Lupron, but that's standard. You don't need to do the 3 months. Don't worry about it.
What about BC embryos? I think that's regarding the presentation.
Yeah, so BC embryos, they're showing that there is a significant reduction in success. I think they said 37%. So yeah, there is a decrease in success rate when you have a BC quality embryo. It's still going to give you a chance, but it's not the same chance as a BB embryo.
Dr. V&T, how many eggs to freeze at 38 to feel safe?
I haven't looked at that data for a long time. At 38, I think it's between 30 and 45 eggs that are needed to succeed, to feel safe, and that's for 1 or 2 babies. So yeah, there's quite a few.
Hi, Dr. V&T, is Gonal F or Recavel better for high AFC?
That's a great question. There are no head-to-head comparisons. They're probably both very good drugs. So I think different people will respond differently. So you really need to individualize a little bit, but they're both going to be very strong drugs. I've got one from Stephanie. How successful is Lupron Depot for IVF used for possible adeno? So there aren't actually any good studies on this, but I can tell you that Lupron and letrozole together are beneficial. From a good study that I really appreciated, and we've started using that protocol quite a bit, and it works for us. Lupron alone has not consistently been shown to improve the outcome of your embryo transfers when you have adeno and endo. There are some studies that say that it does, some studies that say that it doesn't, so it's not consistent. But Lupron and letrozole together basically shuts off your estrogen completely, and that is very effective. Dr. Victory needs a moderator.
There's somebody in there. Hi, Super Dr. V and Sidekick T.
Someone
Can
say.
we exercise after an FET?
Oh,
What kind of exercise is safe? And can I bike ride? Slow, casual pace.
so we're slowly coming up with a video on exercise and pregnancy, so that'll be available soon. And then with regards to the amount of exercise, low-key stuff is fine. So like an elliptical, a very safe treadmill, that kind of thing. But don't be jumping onto a full tilt treadmill uphill or something like that. As far as how much, you know, like half an hour of walking or swimming or elliptical is probably fine. Not very intense. Try and keep your heart rate under 120. And I certainly wouldn't do it in the first day after your embryo transfer. I would give yourself that 24 hours to acclimate. Beyond that, low-key exercise is fine. It can even be beneficial, but intense exercise is probably not a great idea. We do have a video coming out on that, so bear with us while we get that ready.
Hi, Super Dr. V and Psychic T. Can we exercise? Oh, sorry. Hi, Dr. V and T. I've heard that biotin, vitamin B7, can alter urine and blood tests.
Yeah.
I've been getting strong positives on all HCG tests except for the first response. Could this be the reason?
It's possible. If you're taking biotin, it can mess up hormone assays, so you have to be careful for sure.
Hi, Dr. V&T. For operative hysteroscopy for adhesion, balloon, estrogen, antibiotics with a minimum invasive surgeon, anything else you'd recommend to recover well?
Good surgeon, antibiotics if they think they're necessary. Avoid inflammatory events afterwards, whether that's infectious or dietary. Otherwise, no, just clean surgical technique and a good operating technique for sure.
If your patient does laparoscopic surgery, do you still do any suppression after with Lupron before a transfer?
I do. If they have endo or adeno, we will operate and then we'll suppress them. In fact, I think that's a big part of why our endo protocol works so well. So yeah, we do.
What is the vitamin D levels you like your patients to be before an FET?
75 nanomoles per liter or more.
What's your protocol for a FET if I had a positive receptiva DX and ERA that is post-receptive?
So ERA is useless. Ignore your ERA. It's been proven in too many studies for me to list now. Ignore the ERA. The receptiva DX is also useless. It is not predictive of anything. So don't use the receptiva DX. It's of no value to you whatsoever. So if you are worried about endo, get a laparoscopy and be evaluated. If you don't want to, go through the surgery, you can use an endo protocol. So as an example of an endo protocol, and I'm not saying you should use this, just an example, Lupron and letrozole for 3 months first, then a letrozole-based protocol, and then you go through your stimulation with the letrozole. We use multiple supplements, NAC, coenzyme Q10, resveratrol, ALA, curcumin. And then on top of all of that, you're going to use high-dose progesterone, and then you're going to do your embryo transfer. So that's our approach to it, at least. Carly is asking how much methylfolate. I would use 5 milligrams of methylfolate. That's going to be important for anyone going through IVF and anyone with a history of, for example, if somebody had a history of neural tube defects, that kind of thing, that can also be useful. So we use for all our IVF patients, and certainly for those who have previously had any kind of problem. Good question.
Can you talk about growth hormone in IVF for people with poor egg quality? If helpful, how should it be used?
So we use it. There are studies that show improvements in blastocyst development and egg maturity. I haven't seen anything that talks about egg quality. but you do get better quality blastocysts in some studies. So we're just using 2.5 per day starting 2 weeks before the stim. I'm still not 100% convinced it works, but it does seem to be helping people. So we have been using it more and more lately.
What is the wait time for genetic testing of embryos?
Depends on what kind of genetic testing. Normally about 2 weeks, maybe 3.
Do you recommend holding off on trying when waiting for results from a natural cycle?
Do I recommend holding off on trying while waiting for results? In other words, should you stop having sex because you're waiting to see the results of your natural cycle? No, have sex. The ejaculate is good for priming the uterus before, and afterwards it's a great stress reliever and will facilitate better success rates if you're less stressed. So don't stop having sex because you're waiting. That's counterintuitive. Don't do that at all.
Hi, Dr. V and friend T. I found an allergy immune doc who is open to prescribing SCIG.
Yeah.
She wants to see peer-reviewed studies on IVIG or SCIG and fertility. Are you aware of any? I'll email you.
Yeah, there's loads. There are many. The problem is it's controversial. Some studies show a benefit, some studies don't. It depends on which study population you were looking at. That's something we reviewed last week. So definitely there are some studies that show a benefit. Again, there are some studies that don't show a benefit, but we have been using it with very, very good success. So yeah, there are lots of studies. If you go into PubMed, so type in PubMed and it'll pull up National Institute of Health Library. So if you type in PubMed, you'll be able to go in the search bar and then just type in IVIG and IVF. You'll find a million studies. The problem is you got to really go through it over and over and over again to figure out which ones are valid and which ones are not.
Hi, Dr. VNT. No question today, but just a big thank you for your kindness and support today.
Thank you. You know, actually, one of the most common things people say to me when I do consults with them now, and it's unfortunate you don't get to be there for that, is that they end up getting, a very sort of appreciative tone when we start the conversation, because they'll say, we just want to thank you guys both for all the work that you do on this. It's so helpful, and I love the fact that we're actually making a positive change for people. Carly, you're like our number one questioner. What happens if someone goes into preterm labor while on blood thinners? Definitely not ideal, but it happens all the time. The issue is, were you on therapeutic doses or were you on prophylactic doses, and which one were you on? So if you're on a prophylactic dose of like a low molecular weight heparin and aspirin, it doesn't increase bleeding. So most anesthetists are comfortable, although not all. If you're on a therapeutic dose, you cannot get an epidural or a spinal. You have to be put to sleep or suffer through it, basically. So good question. Don't scare everybody off.
Regarding age factor, how old your patient should be before you ask them to stop retrieval/transfer?
55 is what our ethics group has recently been talking about, and that's the age they want to set it at. They don't want to do any over the age of 55, maternal age of 55. So I haven't seen a report from them yet, but that's what they're talking about. Carly, no one has to do anything they don't want to, but you should, because the studies support having a blood thinner for the 5 MTHFR gene mutation. You should take both.
Dr. V, regarding, what glucose test do you recommend to your patients? 1 hour versus 2 hour. I passed 1 hour, but baby is measuring 90th percentile, is now going again.
So the 1 hour is fine as a screening test. That's what we all use. And then we do the 2 hour if you fail the 1 hour. You might just genetically have a big baby, and that's okay. There's nothing wrong with big babies. They're really cute and pudgy. Plus, they make you all strong because you're hoisting around this big, heavy baby.
My wife likes to eat their cheeks. That's what she says.
Yeah. I used to nibble on my kids quite a bit.
There you go. Hi, Dr. V&T. Love your lives.
Oh, thank you.
Thank you for always sharing your knowledge. I'm 11 days past the trigger shot.
Okay.
Did at-home tests and got very faint positive. Can it still be false POs due to shot?
If you triggered and it's more than 5 days past, you should be no longer demonstrating a significant HCG level. Depends on how much you triggered with, but it should be wearing off after 5 days. If you didn't trigger, no, you'd be legitimately showing a positive preg test. So if you took an HCG trigger, it could still linger. So the key is the line getting darker or lighter? Because if you took a trigger, the line can only get lighter. If you did not take a trigger, then any line is a positive. And if the line is getting darker, even with a trigger or without, you know you're pregnant.
Your favorite niece, Jessica. Apparently.
Rahi Junam. Oh, hi, Jess. That Jess. I was like, what? Hi, Jess. It's good to have you here.
It's a fact. You are both awesome. Question.
That's cool.
What is the importance of Lupron Depot on day 21 for a FET? Does the letrozole FET use a natural corpus luteum or medicated? Thanks.
So the importance is there's a Cochrane meta-analysis that shows that Lupron is actually beneficial prior to your frozen embryo transfer. So when you, or as part of your frozen embryo transfer. So when you integrate the Lupron into it, you actually do a bit better. So that's why we use it. And Cochrane meta-analyses are pretty strict and rigid and well done, generally speaking. So I tend to trust most of what they have. So that's a big part of the reason. We don't really care if you have corpus luteum progesterone or synthetic progesterone. You just need to get your progesterone level high enough. Yeah, I mean, we're getting very, very high success rates with untested embryos and even higher success rates with tested embryos. So in our program, I think we're actually getting close to the threshold of what's even possible. You're never going to get 100%, but we are getting very, very close to that right now. So I don't see a need to be reinventing the wheel, so to speak. When the success rates are that high, I'm pretty happy. Yes, Jessica, you can't keep talking to me, dear. And that's Uncle Rahi to you, not Hey Rahi. Yeah.
If you suspect endo, do you always do lap to confirm, or would you consider going right to Lupron for suppression?
You know, that's a great question. And the problem with that is Lupron's not without its share of risk. So I had this discussion with a lady I spoke to on the weekend, and the answer is, like, Lupron's not harmless. Lupron has a lot of side effects, and some of them are positively evil for 3 months, right? So hot flashes, night sweats, mood swings, vaginal dryness, sleep disturbance, decreased sex drive. It's not a pleasant experience for most women. In fact, it can be pretty horrible. So I think that is something that definitely is kind of food for thought or cautionary, that you shouldn't just dive into doing Lupron. You got to really think about it before you do it. So that's kind of critical and important to note. I think that's something, important. Yeah, so I don't just give people Lupron. I'd much rather operate on them and make sure that they're okay, because surgery has risks too, but it lingers for 4 or 5 days and then the pain's over and now you've improved their chances of success. With Lupron, it's in you, and then if I'm going to reverse it, which isn't always entirely possible, I got to put you back on hormones, which isn't good if you have endo, because now I've defeated the whole purpose of giving you the Lupron. So we like confirmation before we give you medication that's that strong. I forgot migraines. Let's have a toast.
Oh, who knows what that comment is? It's gone.
I have no idea. I forgot migraines. Migraines. Oh, I'm sorry for the Lupron. Yes, migraines too. 1,000 pardons, Carly. Yeah.
What is your
any more
protocol
questions.
for endometritis?
Well, an endometritis protocol, in my opinion, is not a protocol. You actually need to know what you're dealing with. So one of the big problems in the endometritis world is people are not being treated appropriately because they're just being given antibiotics without actually knowing what they're treating. So if you look at a fertility report, the fertility report will tell you, for example, the patient has this bacteria and that bacteria, and they have this and they have that, and they go through all of that, and then you actually know what to deal with because some bacteria need, for example, azithromycin or doxycycline. And then the next category needs cloxacillin or moxifloxacin. And then the next category needs Clinda or Flagyl. You can't treat everybody with just one antibiotic because you may not be giving them the right antibiotic, and you could be actually making it worse by killing off the good bacteria and leaving more space for the bad bacteria to take over. So we don't have a protocol. We do very specific testing, which tells us exactly what we need to treat. We then treat it, and then we retest to make sure that we did it right. And to me, that's the only approach that makes sense. The rest of the approaches are illogical. I don't mean to sound like Spock, but...
What's your opinion on an isthmus seal?
Hi, Candace. What's my opinion on an isthmus seal? Avoid it at all costs. So an isthmus seal is the defect in the uterus, and there is very good evidence that it can compromise your success. Mostly it depends on whether blood, bacteria, and fluid are collecting in the uterus as a result of the isthmus seal. Not all of them do that, but if you have one that's more substantial, there are studies that show that treating it improves your chances.
Hello, Dr. Genius.
Oh,
Yeah.
not a genius. I wish.
When should prog test be done in
My
a
son's a
modified
genius.
natural FET?
When should prog test be done?
And would you add PIO and or endometrium if this protocol was my only option for undiagnosed endo?
I would add PIO and endometrium because there are studies that show that adding the progesterone to a natural cycle, in fact, there's one coming out, improves the chances of success. So yes, definitely add. As far as when to test, we test 3 days into your progesterone exposure, and then either on the day of your transfer or the day after.
Hello.
Hello?
I'm 34 with a 19 millimeter endometria. Regular cycles,
Endometria?
endometrioma.
Oh, endometrioma. Okay.
Yeah. Gotta keep on your toes here. Regular cycles, 26 to 28.
Yeah,
And we'll be going through antagonist protocol
sure.
with 2 months of Orlissa prior to stims. Do you see a lot of success with this?
Yeah, I'm not aware of any. You know what? I'm going to do that as a topic one of these days. So I'm not aware of any studies showing that Orlissa prior to an IVF stim improves your IVF success rate. So I'll look it up. I don't use it for that purpose. I use Lupron, but Lupron prior to an IVF cycle has definitely been shown not to be beneficial. It's helpful with letrozole prior to FET, but it is not helpful prior to your IVF stim. Now, Vizan is if you're in Canada. If you're in the States, you don't have Vizan, so that's a problem.
How far to separate egg-free cycles? Is 3 months too far apart at 37?
Yeah, it's way too far apart. Just do them back to back. There's no reason to wait. If you look at duostim literature, you can just keep going back to back to back as long as you don't hyperstim. Now, it depends on how many eggs you produce, but if you're producing a reasonable number, you don't need to wait 3 months in between. That's way too long. Hang on. Carly, the answer to your question of if I had success with my first FET, would my chances for a second FET be good as well? The answer is yes. And Lana Crawley, what happens if you go in for lining monitoring for FET and start your menstrual cycle same day? That's fine. I mean, we monitor during day 3 all the time, and everybody's on their period. Do I ever get tired of people asking obvious questions? LOL. No, because we have to educate everybody, and not everybody comes into this at the same level of knowledge. So no, I don't get tired.
For stage 4 endo
Ooh,
/ adeno,
okay.
that was excised 8 months ago. Do you suggest 2 or 3 months of Lupron / letrozole?
3. That's what the study showed. Do you want to hear something really, really funny?
I would love to.
I've been using this pen because it's got like the
I see
little
that.
rubber tip.
Yeah.
So I just realized it had writing on it. It says Receptiva DX BCL.
No way. No way. Oh man, you got to throw that in the garbage and stomp on it.
Oh, that's really bad.
Where did that come from?
I don't know. I pulled it out of my pen bucket.
Oh,
One of the
man.
girls.
This
must have
video
dropped
is
it.
officially sponsored.
Yeah, it doesn't work, so don't bother.
Yeah,
Anyways,
it doesn't work.
the pen works fine. I mean, the pen works. I can say that.
There you go. The pen works. They did a good job with the pen.
That's bad. That's really bad.
That's too funny.
Yeah.
The irony.
I can assure you there's nothing in there that says error test.
It's pretty good. For those that know.
If there was, it withered and died a long time
I have
ago.
no doubt. Do you do a lap for endo yourself in your clinic? The arm just made it.
Tarek just fell off camera, which was quite amusing. I don't lap people in my office, but we lap them in the operating room at the hospital. Yeah. And I do all my own surgeries.
Hello, both. Heart. What day should you test AMH, progesterone, FSH, prolactin, and TSH all the same day? Thanks.
You can do them all on day 3, except for progesterone. That should be day 21 to 23 normally. The rest of them do on day 3. Have I ever transferred embryos that are 24 years old? No, Candace, I've never transferred embryos that are 24 years old. But the old record was 26, and there was somebody that got pregnant. And the new record is apparently 30. So somebody transferred 30-year-old embryos and they still had a pregnancy. That's pretty cool.
That's pretty cool for sure.
It is cool. I mean, when you think of how far we've come, that's pretty amazing.
Hello, both. Oh, I think I did that. Yeah, I did. How long do you keep your patients on progesterone when pregnant?
Oh. Okay, so I'm a definite outlier. In my practice, I keep my patients on PIO till 12 weeks. And then once they have graduated off of the PIO, we put them on the vaginal, but I cut the dose in half. And because there's a higher risk of preterm labor in fertility patients, I actually keep my patients on their progesterone until they're 36 weeks so that they're out of the preterm labor deal. What's the oldest embryo I've personally transferred? You know, I actually don't know if I have the answer to that. I think 8 years, 9 years, something like that. It's been a while. Yeah, reasonable number.
How to prevent hematometra?
Hematometra?
Hematometra.
How to prevent it?
Mm.
Oh. Usually people get hematometra when they've had an endometrial ablation or like a fibroid removal or some kind of damaging event inside their uterus. So A, avoid the damage, and B, make sure you've got a surgeon with a huge amount of skill and then experience and then knowledge and quite frankly common sense. Because if I do a case where I take out a huge fibroid and I can see that the fibroid bed is raw and it's bleeding and it's large, I put a balloon in the uterus because I know it's going to stick. It doesn't matter if that patient has the healthiest uterus in the world. You're going to cause scarring. So you got to put in a balloon to prevent the scarring. So make sure you find someone that just has some common sense. Sometimes, despite the fact that we're doctors, we don't always demonstrate the most common sense.
I've thought that before, but never in regards to you. To be honest, I thought you were pretty good with that.
So Candace wants to know, do embryos go bad when they've been frozen for so long? No. So the interesting thing here is most studies show no, although there is one study from China that showed that the longer you went from the time you froze your embryos, the lower the chances became. But, you know, we know from many people's reports that even when embryos have been frozen for a very long time, they do well. And there's even one study coming out soon on frozen eggs that shows that there's no detriment to keeping them frozen for longer. And eggs certainly freeze way way worse than embryos do. So if the eggs can stay frozen for a long time, there shouldn't be an issue with the embryos.
I have a question here. I'm not sure how to read it. I can't tell if it's an obscene language or if it's just spelling error. I can't tell what it is. So I'll give you.
You want me to read it?
Yeah, you can read it. This guy right here. It seems decent, but I just don't understand it.
Oh no, that's okay. Good evening, doctor. How long should mild swelling at the injection site last when using Suprafact? Suprafact. Yeah. Not long. 10 minutes, 20 minutes, half an hour maximum. If it's longer than that, you might be allergic to it.
How do you know it was Supra? What made you know that? That's just
the name of the
you know
drug,
the name.
right? Yeah.
I thought it was like beeped out with the
No.
asterisk.
Suprafact. Yeah.
All right. No.
That's probably just a mistake.
What is your criteria for you to use for determining if you will recommend a myomectomy for patients with a intramural and subsersal fibroids and a history of recurrent pregnancy loss, including euploid?
Oh, wow. Well, that there by itself would be an indication. More than 4 centimeters is an indication. Distorting the cavity is an indication. So any of those would be top on my list.
Dr. Victory is the best. Just like that. Just one nice comment.
Oh, Carly keeps us going like
100%.
I love you, Carly. Could I do a government-funded retrieval even if I have embryos frozen already, just for a backup? Yes. There's a lineup, but yeah, you can get in the lineup and do a government-funded retrieval even if you have your own embryos. Government funding for IVF is open to everybody. There's no restrictions other than the woman's age and that you be a resident of Ontario.
Good old Ontario.
Good old Ontario.
What does hyperechoic lining mean at time of transfer?
That it was bright on the ultrasound, which it should be if it's properly progestinized, so that's fine.
What would you do after 3 failed high-quality FETs? 1 programmed and 2 mod natural.
I'd do a consult with you and figure out what went wrong. So those are the kinds of questions where I need to meet you, talk to you for an hour, which is what I always do. Find out everything about you, about your partner, vitamins, supplements, weight, health, alcohol, smoking, drug use, history, what were your embryos like, what protocol did they use, what supplements were you on, what have they measured, have they analyzed your thyroid, your vitamin levels, loads and loads of questions. And then we custom tailor a protocol for you that fits your biology and your needs. So reach out to info@drvictory.com, info@drvictory.com, and just ask for a consult.
Thank you. That's one statement. Thank you.
Okay.
For 2 chemicals with FET directly after excision surgery, stage 4 endo-adeno tubes removed, do you suggest RI testing, switch protocol, get surrogate, feeling no hope, my body can carry?
So first of all, I'm really sorry you're going through that. That's a lot to bear, and we have loads of resources for people that are struggling. So if we can help you, let us know. But I need to know you and know your history and exactly what they did for you and how it was done before I can tell you if you need to go down a different path than the one you're choosing. And it very much depends on how many embryos you have. So definitely reach out. I'm happy to talk to you about it. info@drvictory.com. There are answers for you. I just need to figure it out for you first.
Dr. V, do you have a favorite cocktail supplement for males?
So I don't have a favorite cocktail of it. We just use the pre-made ones. And I'm not specific about any one product over another. The 2 that are available at our pharmacy are actually there's 3. There's an NFH product, there's Fertile Pro, and there's Pro Fertile. They're all fine. If you find something else that you like, that's probably fine too. Carly wants to know if she should get her levels checked. No, you should not get your levels checked. User 9933141263522.
I love that you read the username.
Yeah. How critical is knowing your AMH levels prior to IVF? I have chronically high estrogen levels. Yeah, they're important if you want to gauge, and only a gauge of how many eggs you are going to produce, which can help guide how many times you're going to need to do it. But that's basically the only thing it's useful for.
Had silent and deep endo excised.
Cool.
Do you recommend modified natural FET protocol, letrozole for 5 days, trigger shot, then progesterone?
I recommend 3 months of Lupron and letrozole, then following that a letrozole protocol. This is what I recommend to my patients. You need to talk to your RE, but I give them Lupron and letrozole for 3 months. Then we do a letrozole protocol, lots of supplements, and then we do high dose progesterone, and always double progesterone because the studies support that.
Ready?
Ready for the last question? It's past 9.
Okay.
Are there a million?
No, there's not a million.
Okay.
All right, I can give you this one. This will be the last one to end it on.
Okay.
Doctor thinks uterine PRP 2 days before an FET can ruin the lining and affect the pH. What studies can I show?
Pretty much every single study on PRP. And the lining, where is the, I can't get in because I'm sharing, right?
I can unshare you if you really want.
I might be able to access it from here. Let me see. Maybe it was in here, actually. I don't know. Oh, give me a minute, team. Let me see if I can find PRP.
You know, going back to Carly's question about do you ever get
Carly
tired?
had 40 questions.
Yeah, the one about how do you ever get tired of people asking
asking obvious questions.
obvious questions?
Yeah.
I actually enjoy hearing about doctors that have no idea what they're talking about. That's my favorite question because I can answer it. Like this one right here, I felt I could answer it, so I felt pretty good.
I met a very famous doctor that you will know, whose name I will not bring up, when I went to that Canadian fertility show.
Sure.
Because he and his very inexpensive clinic were there.
Oh, really?
Yeah.
I could have educated him.
Here you go. It's in, which journal is this? Well, here's one called The Effects. Here, let me screen share it.
Screen share? Okay. It's still there. You should be able to.
Nope.
No, it's there.
It is now. It disappeared for a sec. There you go. The effects of autologous platelet-rich plasma on pregnancy outcomes in repeated implantation failure patients undergoing frozen embryo transfer, a randomized controlled trial which showed a benefit. Chemical pregnancy, clinical pregnancy, and live birth rates were higher in the PRP group than in the control group.
Oh.
Yeah. So your doctor is...
Just set up a consult with me. I'll take care of him.
Your doctor... I never know what to say in these cases because I don't want to call other doctors wrong.
I'll give the comment. That way you're...
Then I'm clear?
Yeah, you're
Go
clear.
ahead. You can say it.
Oh, no. I think I said enough. More than that, I'm going to have to bleep it.
Yeah. Look, it's right there in black and white. Your doctor needs to read more, I guess, is my response. I don't know what to say for these situations. You know, all the doctors mean well, but there's a difference between living and breathing this every day and not living and breathing this every day. So, yeah, I do. I really live and breathe this every day. I'm going to close down the show. I have to say, I hope you all had a lovely long weekend. If you're in Canada, if you're in the U.S., happy Memorial Day weekend, which is coming up. I have to thank my amazing, amazing, amazing wife, Wendy Victory, who let me have one of the best weekends I've had in decades. and my wonderful mother-in-law who came with us to our cottage. It was an awesome weekend, and I cannot wait to get back. Much love to everybody. And I hope you guys all have a good weekend. Candace politely mentioned on TikTok that she wants Tarek to educate me on how not to swing from his chandelier. And we're going to close on that note. Oh, goodness. Good night, everybody. See you again next week on Fertility Factor Fiction. Are we on next Tuesday?
I should be, yeah.
I don't think there's a block. Yeah. Next Tuesday. We'll see you next Tuesday.